Today we're here to talk about risk assessment in pulmonary arterial hypertension. How important is periodic risk assessment to the management and survival assessment in patients with pulmonary arterial hypertension? So we've learned a lot about risk assessment and predicting mortality from the REVEAL equation and REVEAL risk score. As you may know, REVEAL is a large U.S. database that looked at almost 3,000 patients and created a risk score based on 12 variables which were important in the prediction of 1-year mortality based on dividing these patients into 5 risk strata. If utilized at follow-up, it predicts outcome for an additional year in prevalent patients. The 12 independent predictors of survival were identified, and they were used to generate a prognostic equation based on the Cox proportional hazard multivariate analysis. And there's a simplified REVEAL risk score that was developed from the REVEAL equation. Multivariable model coefficients were replaced with integer values to create a risk calculator, and there's very little loss of discrimination compared to the full equation. Here's an example of the REVEAL risk calculator. You can find this online. It's pretty easy to do in your head too if you just have a little card. You put these variables into the risk score. You add up the variables, the numbers, and then you add 6. And then that puts a patient in a different risk strata. The lowest risk strata is a score of 1 to 7. The highest risk is greater than 12, and you can see the different risk strata in between that. And you can see, based on this survival curve at 1 year, that these different risk strata differentiate patients. They predict the mortality based on the risk strata. And then the change in REVEAL score is also predictive, and an additional year of survival can be predicted based on this. Particularly if your REVEAL score increases, the prognosis is much, much worse. As you can see that on the left, the change in the REVEAL score, and on the right you can see the absolute score at follow-up predicting another year of survival. And if after a year you're still in the highest risk strata of a score greater than 12, your survival is particularly poor. About half of the patients die in that ensuing 12-month period. There are other ways to assess risk, and this is the table that is very famous now from the 2015 ESC and ERS risk assessment in pulmonary arterial hypertension from those guidelines. This table looks at a number of determinants of prognosis that we have looked at for many, many years, mostly on observational data, and it gives some cutoff values that portend a lower risk, what they anticipated to be a less than 5% 1-year mortality, an intermediate risk, which they projected to be a 5 to 10% mortality, and a high risk, which they projected to be greater than 10% mortality. And some of this is very obvious. For example, clinical signs of right heart failure. If the patient has those, that's a very poor prognosis. That puts a patient in the high-risk category. Progression of symptoms, the more rapidly a patient is progressing, the worse their risk is. Syncope, as we know, is a very bad sign in patients with pulmonary arterial hypertension. Generally, it occurs while exerting themselves in some way and represents the poor augmentation of cardiac output with exercise that then leads to suboptimal cerebral perfusion and syncope, and that's a very ominous sign. As crude as it is, as much as it's been criticized by some people, functional class really is prognostic. This has been demonstrated in many, many observations. So functional class of 1 or 2 is generally a very good prognosis. Functional class of 4, those patients have a very high risk of death in the ensuing year. And functional class 3 is more of an intermediate range. 6-minute hall walk has also been criticized, and the cutoffs here are from large databases. The hall walk of more than 440 has been shown in databases to be associated with a good prognosis, less than 165 with a poor prognosis, and then there's the intermediate in between. Some people do cardiopulmonary exercise testing rather than 6-minute hall walks, and there are some variables, particularly the peak VO2 and the VE, VCO2 slope that are prognostic, and you can see the values listed there. We've learned a great deal about natriuretic peptides over the years, and a low and normal BNP or NT-proBNP is a very good prognostic factor, and of course, as it gets higher, the patient's prognosis worsens. We very frequently use imaging as we clinically assess patients, although really precisely quantifying these imaging variables is difficult in databases and in clinical observations. Probably the one that is most important in studies is the right atrial area. You can quantify that pretty easily. So the bigger the right atrium is, the worse the prognosis is. And a pericardial effusion is a poor prognostic indicator. I personally think the echocardiogram is important for more than that, looking at the right ventricular size and function. It just happens that that's not often included in databases, so we don't have that information, but it's still important clinically to look at that. And the hemodynamics that are most important really have nothing to do with the mean pulmonary artery pressure. They really have to do with the function of the right ventricle. And so that's the right atrial pressure and the cardiac index. And cardiac index can also be reflected by the SVO2. So if you're not in heart failure, if your right atrial pressure is low, if the cardiac output is good, the patient's at low risk. And of course, the high-risk patients have high right atrial pressures and low cardiac index. That's bad. And so it's important to remember that we need to continuously assess the risk of our patients. And there are many ways to do that. We look at the clinical assessment, I think, is very important. You sit down, you talk to a patient, you examine them, and you get a lot of information there on functional class, the progression of symptoms, the signs of right heart failure, and the presence of syncope. We very frequently do an exercise test at a clinic visit. At my center, we get a 6-minute hall walk with just about every clinic visit. And at other centers, cardiopulmonary exercise testing is used more frequently. We're drawing biomarkers more frequently, BNP and NT-BNP. We often repeat imaging. And we occasionally repeat the hemodynamics, of which the most important are cardiac index, right atrial pressure, and mixed venous saturation. And it's important to remember that you have to assess all of these variables, and you might see a patient who has some variables in the intermediate risk category and some variables in the low risk category. And as clinicians, we need to really think about all of the information and assess the risk for the patient. And that's one of the reasons it's important to assess the risk via so many different mechanisms. It's very important as we care for patients and as we prescribe patients. So that was an update on the risk assessment of a patient with pulmonary arterial hypertension, some of the conversations that were had at the 6th World Symposium. Thank you very much for joining me today.